Hello, everyone. Welcome back to Karan Academy. I hope you're all doing super well. Today, we're going to be talking about infections of the urinary and the renal tract. Now, I'm sure you've heard of UTIs and pyelonephritis before, but I think a really good way to classify these infections is going to be towards which part of the renal tract they affect. And this corresponds very closely with how they present. So let's talk a bit about that. You know that the lower urinary tract consists of the urethra, the bladder, and the prostate in males. And infections of these would be urethritis, cystitis, and prostatitis. And all of them present slightly differently. And you can obviously have a combination of two or more of these together. And then with the upper urinary tract, you obviously have the kidneys, and infections of the kidneys present with pyelonephritis, or are called pyelonephritis. You need to know that most infections are bacterial, and women are at a significantly higher risk of urinary infections. Their annual incidence is about 10%. That means 10% of all women have at least one UTI a year. And there are a few reasons why this is the case. So let's talk about this as well as some other risk factors for UTIs. Women have a shorter urethra, so the distance between the urethral opening and the opening of the bladder is much shorter, which is why it's going to be easier for the bacteria to travel upstream. The urethra is also closer to the anus, and as we discussed this later, the most UTIs are because of fecal spread, or bacteria that's usually found in the rectal passage, then eventually finds its way to the urethra, and then up the urethra to the bladder, kidneys, and so on. Pregnancy is a big risk factor for UTIs as well. And what you need to know is that asymptomatic bacteria is very, very common in pregnant women. What asymptomatic bacteria means is that they have an infection, which means they have bacteria in their urine, but they don't usually present with symptoms. And the reason this is important is that asymptomatic bacteria is linked with high levels of complications, both for the fetus as well as for the mother, especially during the birth and beyond. This is also the reason why we screen all pregnant women for asymptomatic bacteria, and that we perform urinary dipsticks across their pregnancy. And lastly, being of a postmenopausal status is also a risk factor for UTIs. This is broadly because of two reasons. Firstly, with old age, and age is a risk factor as well, you have change in the vaginal flora. And the vaginal flora is really crucial in kind of maintaining normal defense mechanisms. As you lose that, you put yourself at a high risk of infections. Also, postmenopausal women often have change in the pH of their urine. So normally pH tends to be rather acidic, or on the acidic side. And this is also one of the body's ways of combating UTIs. However, postmenopausal women have a slight change to an alkaline or a relative alkaline pH. So the urine becomes a bit more alkaline, and this puts them at a high risk of infections. You can also have structural abnormalities, so actual anatomical issues with the urinary tract, which puts you at a higher risk. The important one you need to know is something called ureteric reflux. So normally, the flow of urine is unidirectional, right? So it goes from the kidneys to the ureter to the bladder and doesn't flow the other way. The reason it doesn't flow the other way has to do with the entry of the ureters into the bladder. So normally they enter at an angle, and this angle allows the creation of a one-way valve. So when the bladder constricts, instead of urine flowing up the ureter actually closes or collapses upon itself because of that angle and the pressure of the bladder. And this prevents the flow back of urine, which is really important, because if you lose that, you can end up with reflux. That obviously will also lead to the flow of bacteria up the urinary system and to the kidneys. And lastly, it can also cause something called hydronephrosis. Strictures, stones, and BPH all function on the same principle. All three of them can obstruct the flow of urine. And as you know, stasis is the basis of infection. Recent antibiotic therapy can also cause UTIs indirectly by affecting the normal flora of the body. This refers to both the normal vaginal flora, ureteric flora, as well as the anal flora. So by, again, disturbing the natural flora, you often lose some of those natural defense mechanisms. Recurrent UTIs is another big one, which is why I think one of the most important questions you need to ask any patient whom you suspect a UTI in is, have you had UTIs before? And if you have, how have they been treated? Because if the patient has a known resistance, you would obviously consider that. That's really important as well. Next, we have sexual activity. Now, sexual activity, obviously, through direct contact, can transmit bacteria, so it can cause STDs as well as UTIs. And the really important thing you need to know is that not voiding post-sexual activity actually increases your risk significantly. So pro tip, whenever you do have sex, please pee after sex if you can. That really helps. Next, we have immunosuppression, which is a risk factor for all infections, not just UTIs. And then we have diabetes. Diabetes causes or increases your risk for UTIs through two mechanisms. Firstly, you can have issues with your immune system, and that's going to put you at a higher risk. But more importantly, with high levels of glucose in your blood, you're also going to be peeing out quite a bit of that glucose. And high levels of glucose in the urine, called glycosuria, puts you at a significantly high risk of these infections, because most of the bugs we talked about are aerobic, and they use glucose as nutrient-rich food, which is why patients with diabetes always look for UTIs. Another common thing you need to know is that certain diabetic medications can also increase your risk further of UTIs, particularly medications like SGLT2s work to reduce the level of glucose in the blood by increasing its excretion through the urine. So if you now are peeing out more glucose, that again, further increased risk of UTIs. In terms of causative bugs, there are 6 important bugs you need to know of. These are E. coli, Saprophyticus, Enterococcus, Klebsiella, Proteus, and Pseudomonas. Important points. The most common one by far is E. coli, causing 75% of UTIs. Second is Saprophyticus. You need to know that Enterococcus, Klebsiella, and Proteus are all found in the gut, which is how they cause UTIs through that transmission. And the third point I think is important to know is that Proteus mirabilis, which is the full name, is linked with the formation of struvite stones. So struvite stones are kidney stones that are composed of the crystal struvite, for anyone who's keen on crystals. Struvite itself is composed of 3 components. You have magnesium, ammonium, and phosphate. The reason you get high risk of these stones is that Proteus mirabilis, as part of its metabolic process, excretes ammonium as a byproduct, or ammonium ions. These ammonium ions collect magnesium and phosphate that's also found in the environment to together form these crystals and stones. And one of the scary complications we worry about are these huge calculi called staghorn calculi, commonly found in the renal pelvis. A good way to remember that is seek PP, although from an infectious disease perspective, that might not be the go-to advice. And that is a mnemonic that stands for Saprophyticus, E. coli, Enterococcus, Klebsiella, Proteus, and Pseudomonas. So how do they present? So I'm sure you've come across a list similar to this at some point. So they present with dysuria, smelly urine, hematuria, increased frequency and urgency, suprapubic tenderness, poor stream, pissons d'eau. And if they are, or if the infection is spread to the upper urinary tract or to the kidneys, they would present with fever and flank pain. But let's break this down a bit further, right? So we've talked about, so for those of you who might not be familiar, so I'll just quickly explain what each of these terms are. Dysuria is painful urination. Hematuria is blood in the urine, which can either be microscopic or macroscopic, which means it's either visible only through a microscope, or it's frank, which is red blood, or red pee, which is rarer in UTIs. Increased frequency, which means you want to go more often, or you have to go more times in the day than normal. Increased urgency, which means that all of a sudden the kind of rate of onset of the urge to pee is much quicker. So all of a sudden you might have a strong urgency to pee. Suprapubic tenderness, which is where the bladder is. Poor stream, and pissons d'eau, which means that, which refers to this phenomenon where you have a strong urge to pee shortly after you've already peed. Whenever you see fever or flank pain, you worry quite a bit, as both of them are red flag symptoms. The reason for this is that Most lower urinary tract infections, so your cystitis, urethritis, prostatitis, all of them should not present you or do not present usually with a fever. Additionally, if you have pain in the flanks, which are kind of the towards the back side of your or on your back or towards your side, that usually indicates that there is an infection of the kidneys and is a red flag thing we look for. Instead of, or a better way to, or an easier way to remember that is looking at which part of the actual tract is infected and what that infection translates to in terms of symptoms. So if the urethra is affected or inflamed, you will have pain as urine passes through it. So dysuria as well as smelly urine. If the bladder is inflamed or infected, you might have hematuria, as some of the superficial vessels might get engorged, inflamed, and break, leading to slight bleeding in the bladder. You can have increased frequency and urgency because when the bladder is inflamed and irritated, it's a threshold for identifying the stretch response, which is how your bladder knows that you have to go, is much lowered. So the threshold is lowered, which means that you are much likely to want to go much quicker. And often you can also have suprapubic tenderness, which is an examination finding we look for, because again, the bladder is inflamed. So pressing on that might elicit tenderness. And then we have prostatitis in males. If the prostate is inflamed, that can cause poor stream because the urine has a harder time passing through the prostate. And pis en deux, again, because you have difficulty passing the urine itself, you might think you've gone, or you might think that the bladder has been emptied, but it actually hasn't, which is then why you have to go very quickly again. It's slightly different to urgency. So now moving on to investigations and diagnosis, we always like to break them down into our bedside, bloods, or tests that you actually send off to a lab, and then imaging. In terms of bedside tests, a urine dipstick is a test you should always perform if you suspect a UTI, and blood sugar levels if the patient's diabetic. As we know, diabetes is a risk factor. In terms of bloods, you can do an FPE looking for leukocytosis. You can do a UEC, we're looking for renal function, especially if they have CKD and have now a superimposed infection. Has the renal function been affected? And CRP, which is an acute inflammatory marker. That's although non-specific. A urine MCS is a really good test that firstly looks for what is the bug, how much of it is there. So it tells you the colony count and what antibiotics would it be sensitive to. So it's really good. And then blood cultures if we suspect urosepsis or if we suspect a complicated UTI. In terms of imaging, we can do an ultrasound or a CT scan of the urinary tract, and this is often done if we suspect an anatomical or structural cause that might be contributing to UTIs. Although this list is important, I think it's more important to know what do you order in which circumstances, right? Because UTIs can present in a broad range of situations, so we need to know what to do when. Let's say you have kind of a very stock standard, typical presentation of a UTI. You have a middle-aged woman who's come in complaining of a bit of pain when she passes urine and a bit of tenderness. She doesn't have anything that might indicate that this is a complicated UTI. So she doesn't have a fever, doesn't have flank pain, doesn't have any systemic signs otherwise. Pretty stock standard, right? So if everything leads to a UTI, you don't really have to perform a lot of investigations. You would always still be suggested to do a urine dipstick because that's a very easy test to do. You can do it in your GP clinic with pretty much instantaneous results. However, you don't always have to do, or you don't have to do a culture MCS in this case. So an MCS or a urine MCS stands for microscopy, culture, and sensitivity, right? So microscopy tells you the gram stain and if it's a gram positive or negative and what it looks like. Culture tells you what it's actually grown, and sensitivity tells you its sensitivity to certain antibiotics. So when do we actually do a culture, right? And when do we go that extra step and send off extra blood work? As you can imagine, a urinary MCS would be really good if we aren't really sure if there is an infection or not. So every situation where we're unsure, you can go and do a urine MCS. or if we have the need for targeted antibiotic therapy. So some of those circumstances might be a complicated UTI, a febrile UTI in a male, because that is not your typical demographic. So we want to confirm the diagnosis. Pregnant women, because we always want to treat them aggressively with the right antibiotics, and older patients, especially those above 65. This is because UTIs in older patients can present quite atypically. What I mean by this is it may not always present with your dysuria frequency and so on. They might have back pain, they might have headaches, they might have shortness of breath, they might have slight delirium, and they might not have clear symptoms. So it's always good to confirm this. And also people who have recurrent UTIs. This is because with recurrent treatments and recurrent therapies, we might now be dealing with a strain that's resistant to our first-line antibiotics. So we want to give them targeted therapy. If you have recurrent UTIs or UTIs in men, you always want to screen for structural abnormalities, and that's often done through imaging. That is your ultrasound or your CT of the urinary tract, looking for hydronephrosis or any reflux. In terms of urine MCS, which would tell us the bacterial count, a count above 10 to the 5th power is considered diagnostic, or sorry, this should be 10 to the 3rd power, not 5th. So 10 to the 3rd power with typical UTI symptoms is also enough to call it a UTI. I will correct this, it should be 10 to the 3rd power, not 5th. And that would both be on a fresh midstream urine sample. Here is urinalysis, or your urine dipstick. It's a very commonly done test, and it would be very fair game if you were asked to interpret this. So the way it works is you have a fresh midstream urine collection. You would insert the dipstick, and you now have this chart that's almost on all, that would be on all the boxes, that has these parameters that we're looking at. The numbers usually indicate how long does it take for the test to come back. So when it says 30 seconds, it means that the color change is definitive at 30 seconds. So you insert the dipstick, you wait 30 seconds, and then you can line up your dipstick with the chart to then compare the different parameters. So some important ones that are relevant for a UTI, from a UTI perspective, would be leukocytes, because these would be our white blood cells, and a white blood cell count greater than about 10 to 15 is considered typical of pyuria. Nitrites seen in E. coli, again, really important to look for. Protein, although not very relevant to UTIs, is still an important parameter you need to look at, to look for things like nephrotic syndrome or your diabetic nephropathy that can present with proteinuria. pH, as I mentioned, a lot of postmenopausal women can have alkaline pH, and that would put you at a high risk of infections. Blood, which can be either hemolyzed or non-hemolyzed. Typically, UTIs would present with hemolyzed blood, and most of the blood or most of the hematuria would be microscopic hematuria. This is because although you have damage to the inner bladder wall, it's not going to be significant enough to cause frank red-looking urine. And glucose, of course, if the patient is diabetic and you want to screen for glycosuria. Here is also what an ultrasound might demonstrate from a vesicoureteric reflux perspective. And this is graded from grade 1 to grade 5, depending on how further back is the reflux. So grade 1 is when you have reflux into the ureter without dilation of any of the renal structures. The moment you have reflux into the renal pelvis, that's grade 2. You don't need to know the specifics of 3, 4, or any of them, to be honest, but if you have gross dilation of all structures and reflux into the inner pelvis, that is obviously going to constitute grade 5, and that's severe reflux and often presents with hydronephrosis. In terms of our antibiotic treatment, I've broadly split this up into our lower urinary tract infections, our pyelonephritis, and then asymptomatic bacteria. With UTIs, or our lower UTIs that are uncomplicated, most of them are going to be E. coli. And therefore, empirical treatment in the community, if they don't have pyelonephritis, would be trimethoprim. It's important to also know that 20% of these patients would be typically resistant to trimethoprim. It is at this point that we might consider doing a urine MCS to give us specific information about the antibiotic sensitivities. Of course, if the patient has fever or flank pain, that would be pyelonephritis. And pyelonephritis is not a condition that would usually be managed in the community. It, in most cases, would at least validate or warrant hospital admission for a few days. The reason we use more aggressive antibiotics is that our stock standard trimethoprim or fosfomycin, that's another agent you can use, doesn't typically penetrate renal parenchymal tissue enough to treat it adequately. And therefore, we need something that's a bit higher. So for non-severe pyelonephritis, so this would be, they might have flank pain, but no fever and are otherwise well. We might consider oral amoxicillin for 14 days. However, if they have any signs of systemic illness, any indications of urosepsis, if they are hemodynamically unstable, if they have a fever, this would require hospitalization, and this would be severe pyelonephritis requiring gentamicin and amoxicillin, and this would typically be given IV, not orally. Lastly, we have asymptomatic bacteria, and the basic treatment principle is the same as that of uncomplicated UTIs. And you need to know that very often, if you even do a test and you identify someone as having asymptomatic bacteria, let's say you just had a patient, you're unsure if they had a UTI, you just did an MCS, and it came back as a bacterial colonization that is not high enough to constitute a UTI, but is still present, you will never ever treat it because we don't want to cause antibiotic resistance, unless the patient is one of the following three. Unless the patient is pregnant, in which case always treat asymptomatic bacteria based on the sensitivities. Unless the patient is undergoing a procedure. Typically, this might be a biopsy, some renal procedure where they're having renal surgery. In all those cases, you want to treat that. Or if they're immunosuppressed. This can be for a wide range of conditions, whether that's iatrogenic or because of infections like HIV, you always want to treat them as well, because the possibility for that converting into a urosepsis picture is firstly more likely, and it's going to happen quicker in immunosuppressed patients than in a typical than in a immunosuppressed patient, obviously. And that's all we had for infections of the renal tract. Thank you all for coming. If you have any questions, feel free to email me or send me a message through Facebook. And as always, please look after yourself and please look after your loved ones.